Hello, my name is Ellen Bowser and I work at the University of Florida Pediatric Pulmonary Center Leadership Training Program. I wanted to first of all thank Chris Staple for asking me to give this guest lecture in your section on respiratory diseases. I am the co-director and nutrition faculty on the PPC Leadership Training Program. So what are we going to talk about today? We're going to talk about our Pediatric Pulmonary Center Leadership Training Program, and I also wanted to give you a snapshot of some of the respiratory and sleep conditions that we see in the children who we care for. We're going to talk about the Maternal and Child Health Bureau, the faculty and the trainees, and then what I wanted to do again was to give you a snapshot of some of the more common and less common respiratory and sleep conditions. Again, I work at UF Health in pediatrics. So we have a leadership training program from the Maternal and Child Health Bureau, which is comes under the heading under the HRSA, or Health Resources and Systems Administration. MCHB's mission is to provide and improve the health and well-being of America's mothers, children, and family. The vision is an America where all mothers, children, and families are thriving and reach their full potential. And there are several goals. The first is to assure access to high quality and equitable health services to optimize health and well-being for all MCH populations. A second goal is to achieve health equity for the MCH populations and to strengthen public health capacity and workforce for the maternal and child health population. Maintaining impact through leadership, partnership, and stewardship. So what is a PPC? The purpose of the Pediatric Pulmonary Center Leadership Training Programs are to improve the health status of infants, children, and adolescents with chronic lung conditions, sleep issues, and other related special health care needs. And we do this through a combination of graduate and postgraduate interdisciplinary training of health professionals. We also do this while working collaboratively with programs that provide family-centered care, public health practices, and critical and cultural competence to address health disparities and access to care. And so if you want to know more about our PPC, at the bottom you will see a fact sheet that's come out from MCHB and HRSA that talks about what pediatric pulmonary leadership training programs are. Just to let you know, there are 6 grant-funded PPCs around the country. They are every 5-year renewable grants. We've had ours at UF since 1972. And it's a 5-year renewable grant. We were just recently refunded July 1st of 2020. So we've just started year 2 of our grant. And this little map will show you the locations of the other PPCs, just like ours. And so it's Alabama, University of Alabama at Birmingham, the University of Arizona. There are actually 2 new centers in California, Children's Hospital of LA and University of California at San Francisco, and then there is another center at the University of Washington in Seattle. So all of these programs have the same grant funding, and basically have the same goals and objectives. So at our PPC, we provide interdisciplinary training of graduate level health professionals. We also develop continuing education programs for practicing professionals. As you may know, most licensed health professionals have so many continuing education credits that they need to achieve to renew their licenses. And so we develop both in-person and online continuing education programs. We also provide direct services. We provide clinical care to infants, children, and adolescents with pulmonary and sleep-related conditions. And then we actually conduct programs and research to advance the knowledge and practice of pediatric pulmonology. We have an interdisciplinary team, and these are the examples of the disciplines on our team. Again, I know that you all are students looking into health-related careers, and so I wanted to let you know, if you're interested in working in pediatrics, what you can do in the pediatric world of healthcare. Our team consists of physicians. They are pediatric pulmonologists. Those are physicians who have completed a 3-year residency in pediatrics, and then they go on to do a 3-year subspecialty in the field of pediatric pulmonology. For physicians who want to become sleep specialists, that is an additional year doing a sleep medicine fellowship. We also have nutritionists, registered dietitian nutritionists such as myself, who are part of the team. We have nurses, both pediatric and family practice nurse practitioners. We have clinical social workers. We have clinical psychologists. What's interesting about our PPC and unique is that we also have a family leader. This is a parent of a child with a chronic illness who has no medical background at all, and she comes in and gives us the family perspective. We need to remember the family when we're working with children and adolescents with chronic conditions. There are other disciplines who do work with our team, including pharmacy, physical, and occupational therapy. It's important to know that all these disciplines, we accept students in those disciplines. So we have trainees who come from each of these disciplines and spend time with us at the PPC. Something else I wanted to mention, again, because it's unique to our center, is our family leader, Angela Miney, actually developed a program called the Florida Family Leader Network. And so it is an active group of families, professionals, and students who are committed to serving children and youth with special health care needs. So it doesn't just have to be pulmonary. We actually put on an annual summit for the Florida Family Leader Network, or FFLN. This year it will be a virtual summit and a 2-day summit in September, and the topic will be grief, loss, and moving forward. The FFLN also has a closed Facebook group in which families and professionals can share information, network. Obviously, no patient information is shared. It's just a way of connecting families with each other and healthcare professionals. Again, it's founded and coordinated by our family leader, Angela Miney. And so I would encourage you to go to the website, which is floridaleaders.org. If you're interested in learning more or becoming a member of the FFLN, and you can go to Facebook and search that and request to be part of that group as well. Okay, so now I'm going to move on because this is a respiratory section and talk about a few of the common respiratory and sleep disorders, the diagnoses that we see in our pulmonary clinic. The first is asthma. We know that asthma is the most common chronic illness in children. And it has a huge public health concern. Unfortunately, we know that there's a higher incidence of asthma in children who come from lower economic status. The hallmarks of asthma or an asthma exacerbation are bronchospasm and inflammation. So bronchospasm around the airways, the muscles get very tight, and then within the airways, there's a lot of mucus that's produced. Asthma is often triggered by allergies, and right now we know in Florida, dust mite is the #1 allergen. What's unique about our PPC is that we actually have a severe asthma clinic, and in that is one of our asthma clinics, but our severe asthma clinic, we actually have a medical legal partnership. So we have attorneys who come to this clinic and help families who may have unmet legal needs. For example, kids with asthma who may have severe allergies to mold. There may be mold on the inside of their apartments, and perhaps the landlord isn't doing anything about it, or the air conditioning isn't working well. Then our medical legal partnership can actually help these families get their services met. The next diagnosis that we see commonly in our clinic is cystic fibrosis. Cystic fibrosis is an autosomal recessive genetic disease, and so for a child to present with CF, he or she has to have, each parent has to have a CF gene. What happens with cystic fibrosis is that there is a blockage of sodium and chloride across the epithelial cells, and what we know is that many organ systems are affected, but the lung and pancreas causes the most morbidity. The life expectancy has exponentially increased over the past 10 years. And so cystic fibrosis for for many, many years was considered to be a pediatric disease. But now we know that more than 50% of all people with CF are adults. And so at UF, we have both a pediatric and an adult CF team, and pediatric and adult CF clinics. We have about 70 pediatric patients with CF and over 200 adults with cystic fibrosis. There are some new medications being utilized. They're called CFTR modulators. And they actually are allowing the sodium and chloride to move across the cells. So it's really affecting the basic defect in CF. And these medications are life-changing. I mean, they are most of the reason for the increased life expectancy. And so it's really exciting to see, again, kids growing up to adulthood and having fairly normal lives despite having cystic fibrosis. I had this picture up because I wanted to just mention that there's a slogan or a logo called 65 Roses, which is often used by the CF Foundation. And the reason it was used is that many years ago, a child with CF had a difficult time saying the word cystic fibrosis. And so I think it was a little girl. She kept calling it 65 Roses. And so, so that's really kind of taken on. And so often many of the benefits, the fundraising organizations will use the term 65 Roses. Again, if you're interested in CF, want to learn more, I would encourage you to go to the CF website, www.cff.org. The next condition I want to talk about is obstructive sleep apnea, or OSA. What occurs with obstructive sleep apnea is there is a partial or total blockage of the trachea and the airway during sleep. It can result in hypoxemia, bradycardia. A lot of long-term side effects can occur if the obstructive sleep apnea isn't treated. We know that OSA is associated with weight status and neck circumference, and the symptoms of someone with having obstructive sleep apnea, and this obviously can occur in children and adults. It's seen more frequently in adults, but we have kids with OSA as well. What you'll hear is snoring, gasping, choking during sleep. With children, they're very irritable and can be cranky during the day because they're tired. The test for obstructive sleep apnea is a polysomnogram or a sleep study, and the treatment, the gold standard treatment is continuous positive airway pressure, or CPAP. And you can see this picture of this little boy is a nasal CPAP. And so what happens with obstructive sleep apnea is the chest wall actually compresses in and compresses the trachea. And so with CPAP, there's actually air being blown into the trachea, so it keeps it from closing completely, allowing the person to have normal oxygen exchange at night. Okay, so now I'm going to move and talk a little bit about some of the less common respiratory and sleep disorders that we see in our pulmonary clinic. The first is spinal muscular atrophy, or SMA. SMA is a genetic illness. It is a progressive neurodegenerative disease that affects the motor nerve cells in the spinal cord. And it affects the muscles that are used for breathing, eating, crawling, and walking. There are 5 types of SMA. Unfortunately, it's the #1 genetic cause of death for infants, and SMA is a disease that is looked at with newborn screening. So when there's a panel of conditions that are screened for after birth in infants, and SMA is one of those. Right now we have a treatment at UF for SMA. It's a gene therapy treatment, so we're excited about this because we feel that this may make a huge difference in the lives of these children. And again, I would encourage you to go to the curesma.org website if you want to know more information about spinal muscular atrophy. The next topic I wanted to bring up isn't exactly a respiratory or sleep condition, but I wanted to mention it, and that is pediatric lung transplantation. We know that lung transplantation is the treatment for end-stage lung disease, and the #1 cause for a child needing a lung transplant is cystic fibrosis, and then interstitial lung diseases. We often see kids need to get lung transplants for that as well. UF is the only pediatric lung transplant program in Florida, and we're really excited because we have a brand new division chief, Dr. Mark Schechter, who is came from Cincinnati Children's Hospital, where they have done many more lung transplants than we have done in Gainesville. And so Dr. Schechter just started with us, and he's really going to, I think, move things forward with our lung transplant program. Dr. Schechter has done over 100 lung transplants. And so I just wanted, again, we've got our website that talks about our lung transplant program and information about Dr. Schechter. It's important to know that there are many issues after lung transplantation. It's not a cure. It's what we say is that we're trading one set of problems, end-stage lung disease, for lung transplantation. So there are issues such as infection, rejection, patients are immunosuppressed, so there are a lot of issues related to that. And the life expectancy is the survival is about 50% for 5 years. So it's not the greatest survival compared to other transplants, solid organ transplants, but the research is going on and we're continuing to be encouraged. Okay, and the last condition I wanted to bring up, it's a sleep condition, and that is narcolepsy. And so narcolepsy is a disruption of the sleep-wake process. And the primary symptom is excessive daytime sleepiness, where someone just is not able to stay awake. And what happens is the brain is not able to properly regulate wakefulness and sleep. It's interesting because narcolepsy, there are two types of narcolepsy. One is associated with a loss of, uncontrollable loss of motor control. So someone with that type of narcolepsy during strong emotions may just lose muscle control. The other type of narcolepsy does not have that loss of muscle control. It's interesting because the peak diagnosis or peak onset of narcolepsy is 15 years and then it again at 35 years. And it can take years for someone to get a diagnosis of narcolepsy. The treatment is really behavioral in terms of having regularly scheduled naps and medication. Medications particularly to keep the person awake when they need to, for example, when they're in school or they're driving a car, something else like that. But again, we see it in kids and adults. It's just a little bit more challenging to diagnose in children. So this was the end of my guest lecture. I hope that I gave you a little overview of our interdisciplinary training program and some of the patient diagnoses that we see. If you are interested and want to know more about our training program or you want to know more about working with children and families, feel free to email me. You can see my email here. It's bauseek@peds.ufl.edu. I would love to have you come and visit us in our clinic, or we can do Zoom discussions as well. So good luck in the future, and have a good day.